So today's presentation is prevention of infection in ICU. Prevention of infection in intensive care unit focuses on care bundles and standard precautions to reduce healthcare associated infections like pneumonia and bloodstream infections. So what are the universal precautions? Universal precautions are the guidelines designed to protect the workers from exposure to diseases spread by blood and other body fluids. So in 1987, the concept of universal precautions was put up. So according to Centers of Disease Control, standard precaution is the outgrowth of universal precautions. Universal precaution was first introduced in 1987 to prevent spread or transmission of blood-borne pathogens to the healthcare providers. However, in 1996, the concept of standard precaution was established to expand course of universal precaution. Standard precaution now constitutes primary strategy to prevent transmission of infectious agents not only to the healthcare personnel but also to the patients and hospital visitors. What are the core prevention strategies? Hand hygiene, standard precautions, transmission-based precautions, care bundles, and environmental control. Hand hygiene is recognized as the most critical measures for preventing cross transmission. It must follow 5 moments, that is, before patient contact, before aseptic tasks, after body fluid exposure risk, after patient contact, and after touching the patient's surroundings. Hand washing should be done at least for 40 to 60 seconds and hand rub 20 to 40 seconds. But hand rub is done whenever we are taking the patient's rounds with the wards, and if the when we should mandatorily wash the hands when the hands are visibly contaminated with the blood or any diarrhea stool of the sample, or after coming from the toilet, or before taking food, or before giving the medicines. So if it is contaminated with such all these things, we should not go for hand rub. We should go for hand wash. So hand rub is just for in between the patients. So to avoid the frequent washing of the hands. So that is only the option for hand rub. Otherwise, if it is visibly soiled, the hands are visibly soiled, we have to go for hand wash. So these are the 5 moments of hand hygiene: before touching patients, before clean procedure, after body fluid exposure risk, after touching patient, and after touching patient surroundings. So these are the steps of hand washing. First step is palm to palm, palm to palm, 4 5 times we should do. Then back of the palm of both sides. Then palm to palm with interlacing fingers. Then back of the fingers opposing to the palm with the fingers interlocked. Then rotational rubbing of the thumbs, right thumb, vice versa, right thumb, left thumb. Then fingertips, rotational rubbing backward and forward with the clasped fingers of left hand in the right palm and vice versa. Then last, that is wrap the left hand over the right wrist using rotational movements up to the mid palm, vice versa. So these are the 7 steps of hand washing. Then come to the standard precaution. It includes consistent use of personal protective equipment such as gloves, gowns, mask, eye protection, especially when exposure to body fluid is possible. So, what are the elements of standard precaution? Hand hygiene, personal protective equipments, respiratory hygiene and cough etiquette, prevention of injury from the sharp objects, then cleaning of the patient care environment, biomedical waste management. Then there are the special precautions known as transmission-based precautions. These are the second tier of the basic infection control used in addition to standard precautions of patients known or suspected to be infected or colonized with highly transmissible pathogens. They are implemented empirically based on infection symptoms like diarrhea or new rash, even before the laboratory results are finalized. So, first is the contact precautions. They are used for the pathogens spread by direct contact with the patient or their environment. For example, Clostridium difficile, MRSA, that is methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococci, norovirus, and scabies. So here personal protective equipment is very important, includes gloves, gown upon entering the room. Patients are preferably in the single room or cohorted. Cohort means the patient with the similar symptoms or similar disease causing agents are grouped together. They are kept in the same room. So if they have the same infection, dedicated or disposable equipment should be used, and the disposable equipment should be disinfected after the discharge of the patient. Then comes the airborne precautions. These are the pathogens that remain infectious over long distances in the air as small particles. Example include TB, measles, chickenpox. So here personal protective requires N95 or higher respirator, and patients must be in airborne infection isolation rooms with negative air pressure and specific air exchange rates. That is 6 to 12 air changes should be there within 1 hour. The patients transported outside the room should wear surgical mask. So these are the airborne precautions. Then droplet precautions. These precautions are the pathogen transmitted via large respiratory droplets. Common indication include seasonal influenza, pertussis, mumps, and bacterial meningitis. PP includes surgical mask upon entry. If transporting the patient, they should wear surgical mask. Special air handling it is not needed. So what are the key measures based on transmission-based precautions? Contact precautions, personal protective equipment required, gown and gloves. The room we can give private room or cohort. Similar, if the patient with similar complaints are grouped together or kept in one room. Airflow, standard airflow, and distance direct, indirect touch. Then droplet. For droplet precautions, surgical mask is sufficient. Private or cohort can be done. Then standard airflow is maintained and the distance more than 3 to 6 feet away from the patient. For airborne port transmission, N95 respirator should be there and we should do the fit testing or fit checking. Then negative pressure room should be provided. About 6 to 12 air exchanges should be done per hour and long range suspension is there, so we have to maintain the distance. So disease specific isolation recommendations are given in this chart. Standard precautions, for example, cytomegalovirus, HIV, hepatitis B and C, aspergillosis, standard precautions. Then contact precautions, MRSA, vancomycin resistant enterococci, adenovirus, diarrhea, Clostridium difficile, rotavirus, E. coli 0157, enterovirus, Salmonella, Shigella, hepatitis A, herpes zoster, shingles, herpes simplex, parainfluenza, respiratory syncytial virus, lice, scabies, chickenpox. Droplet precautions should be undertaken for pertussis, influenza A, MRSA, Neisseria meningitidis, Coxsackie, bacterial meningitis, respiratory syncytial virus, mumps, and rubella. Airborne precautions: chickenpox, disseminated herpes, measles, tuberculosis, SARS, and avian influenza. So SARS actually it was SARS-CoV-2. That is, COVID was considered categorized under the droplet precautions. In the beginning, they told that airborne precaution. Then afterwards, it was found to be droplet precautions are sufficient for COVID-19. Now there is a special word known as care bundles. These are the evidence-based bundles for high-risk procedures. For example, ventilator bundle. So those patients on ventilator, head of bed elevation 30 to 45 degree, daily sedation, vacations, and oral care with chlorhexidine. Then center line bundle, strict hand hygiene, maximal sterile barrier, precautions during insertion, and daily review of line necessity. Catheter bundle, sterile insertion techniques, maintaining the closed drainage system. So this is the photograph showing ventilator associated pneumonia prevention bundle. Head of the bed, head elevation, oral care with chlorhexidine. So cotton swab is moistened with chlorhexidine and it is wiped inside. Then stress ulcer prophylaxis. Then deep vein thrombosis prophylaxis is given. Daily sedation assessment and spontaneous breathing trials. Then Corti bundle, catheter associated urinary tract infection, hand washing, avoid unnecessary urinary catheters, insert urinary catheters using aseptic technique, maintain urinary catheters based on recommended guidelines, review urinary catheter necessity daily. So perianal care or perianal wash is very important. Then surgical site bundle, preoperative bathing, hair removal, surgical site preparation, perioperative oxygenation, optimal time for prevention of surgical antibiotic prophylaxis, use of protocols for intensive perioperative blood glucose control, maintaining normal body temperature. So these are the surgical site bundles. Then centerline associated bloodstream infection bundle, chlorhexidine antiseptics, always perform hand hygiene before the insertion of the centerline, scrub the hand and disinfect all the pores. Then dressing should be properly taken care of. Then hand hygiene, appropriate dressing changes, regular. Then we have to timely remove of unnecessary catheters. So always in each and every round, we have to assess whether it is still needed. If it is not needed, as early as possible, the center line should be removed and patient should be switched to the regular feeding. Then important aspect is biomedical waste guidelines. Biomedical waste management itself is another topic. Just briefly, which guidelines are followed? 2016 guidelines are followed, and after that in 2018 and 19 there was an amendment, minor amendment was there. And as per the biomedical guidelines, 2016 guidelines, four categories of biomedical waste are there. Yellow non-chlorinated plastic bags we should use, autoclave safe plastic bags or containers, autoclavable safe plastic bags and containers. In yellow, non-plastic infected articles like human anatomical waste, then animal tissues, animal carcasses, and those atoms which infected atoms like cotton, bandages which can be burnt, which are non-plastic. Then red container should add infected plastic like urinary catheters, the urine bag, all those plastics which are there, which are infected, which is added in the red. Then white translucent container, it should be puncture proof, leak proof, and tamper proof container for sharps like scalpel blades or injection needles. So sharps. Then blue container, blue cardboard boxes can be used with a blue marking on this. All the glass should be discarded. So this is just briefly the biomedical waste management can itself will be another topic. Precautions during handling needles. Standard precautions must be followed. Work surfaces must be disinfected with 0.5% sodium hypochlorite. Healthcare workers must be immunized against hepatitis B virus. Spillage of blood and other body fluids must be promptly cleaned. Disposable needles should be used. Never recap the needles and proper disposal after use. Engineering control measures. So this is the improper method. Actually, as far as possible, recapping of the needles should not be followed. If you tell the recapping needle, it should be done with a single hand scoop method should be used. Environmental cleaning. For environmental cleaning, triple bucket system is the cleaning method, often used using a trolley with three compartments as shown in the photograph. You can see here. Designed for efficient hygiene by separating clean solution, rinse water and disinfectant, preventing cross contamination, and is a standard in healthcare and clean room environments for thorough washing, rinsing, and sanitizing surfaces. The system uses first bucket soapy water, second for rinsing, and third for disinfectant, ensuring the mop is clean and effectively applying sanitizers for improved cleanliness and infection control, especially in the critical areas. Then, how should be the direction of cleaning? Direction of cleaning should be unidirectional. We should not use bidirectional. And here in this photograph, cleaning of OT is shown from cleanest area outwards. So we have to start with the cleanest area surrounding the OT table. So this is the first, start first near the OT table. Then this is the second, and this is the third, then fourth, and it should be taken outside. That is the fifth one. So start with the cleaner areas and then go to the outer area. And the mopping or cleaning should be done at least 3 times a day. or whenever there is an infected case is taken in OT, we should follow with the uh, cleaning and mopping of the surroundings. Then blood spill management, all the critical areas as well as all the wards should have blood spill management kit. So this is the kit is shown, and there should be board regarding the spill so that no one will accidentally come and touch it or keep feet on it. So blood spill management ICU involves immediate containment, donning full personal protective equipments, gloves, gown, eye protection, absorbing the spill with paper towels, disinfecting thoroughly with high concentration bleach solution, 10% bleach or 10,000 part per mole chlorine for correct contact time and proper disposal of all contaminated materials in biohazard bags, followed by hand hygiene and incident reporting. So this is the blood spill management. All personal protective equipment, goggles, then gloves, heavy duty gloves, and the container to be taken with the. Then you can see absorbent paper should also be there. If such papers are not available, tissue papers are not available, you can use the newspapers also. And even it's not shown here, okay, you should have forceps also for picking up the glass if there is a glass breakage. So spill management, here it is shown, or blood or any body fluids. If there is a small volume of the spill, few drops are there, ensure that all patients, people and staff are moved away from the spill area. We should put the board of blood spillage. Then wear the workman's gloves and other PP appropriate to the task. When shafts are involved, use forceps to pick up the shafts and discard these items in puncture-proof resistant container. Cover the spill with a newspaper or appropriate absorbent material to prevent from spreading. Moisten with 1% hypochlorite solution. Keep it for 30 minutes. In some, they have mentioned 20 minutes. In some, they have mentioned 10 minutes. Wipe the spill with newspaper. Discard the paper as infected waste in yellow bin. Repeat until all visible soiling is removed. Wipe the area with a clean mop moistened with 1% hypochlorite solution and allow drying naturally. All contaminated items should be used in the cleanup should be placed in a biohazardous bag for disposal. So what are the things which are exhausted from spill kit? It should be replaced immediately. And the incidents should be reported and recorded in the register kept in the ward or ICU. If there are large spills more than 10 ml, confine the containment area, wear workman's gloves and other personal protective equipments appropriate to the task, cover the spill with newspaper or appropriate absorbent material to prevent from spreading, flood the spill with 10% hypochlorite solution while flooding. Spill with it should be ensured that both the spill and absorbent thoroughly it should be wet. Then wait for 30 minutes. Remove and discard the paper and wipe the area again 10% hypochlorite and all the contaminated items should be replaced in a kept in a biohazardous bag and it should be disposed as per the biomedical waste guidelines. And what are the exhausted materials in the spill kit? It should be replaced and incident should be reported, recorded in the register. So this is about the important aspects of uh, infection control in ICU. The basic aspects are there. Thank you for your patient listening. Thank you.